Affairs and Policy with NIAMH, which is Northern Ireland Association for Mental Health.
Can you bring your microphone slightly closer to you, I think? Yeah? Yep, sure. That's fine.
We welcome the opportunity to engage with the public inquiry on emergency healthcare, particularly as a mental health organisation, given the Human Rights Commission's role around the UN Convention on the Rights of Persons with Disabilities and reviewing how the state is implementing the right to health under that convention and then associated rights as well. NIAMH is the largest and longest established mental health charity in Northern Ireland. Since 1959, we've been delivering community mental health care through our Beacon services, and that is largely what I will draw on for evidence for the inquiry. Beacon would provide services all across Northern Ireland in each of the Health and Social Care Trust areas, and the range of services would include accommodation, day support services, advocacy, and also what's called floating support, which is basically trying to support people to remain in their own homes. The issues, I suppose, of particular interest to us with regard to the public inquiry is, first of all, its scope and ensuring that there's a strong emphasis on mental health emergency care in the public inquiry. That would be a significant concern for our organisation, that there's a real need to deliver 24/7 emergency mental health care across Northern Ireland in a way that is consistent and equitable. And we would consider that the state has failed to do that so far. Of concern, I suppose, for us is that there would be emergency mental health care for people, but also we would see within mental health significant scope to avoid crises and avoid emergency if there was comprehensive provision for early intervention and support for people. Obviously, in terms of emergencies, people maybe have a crisis or an emergency the first time they experience mental ill health, but often people experiencing crises or emergencies in their mental health are well known to services, and there's a great opportunity to engage with them and support them and avoid emergency situations. We also want to address the issue of how people with mental health problems and their families and carers experience emergency physical health care, which we would see as mainly the focus of A&E. And that would be with regard to both their mental health issues, but also with regard to their physical health issues, because people with mental health issues have massive difficulties in terms of their morbidity, and so they would be likely to present at A&E with cardiac problems, stroke problems, a whole range of physical crises as well, and how that is experienced. And then, I suppose, underpinning all of that is a real concern about the extent and degree of stigmatising attitudes amongst health and social care staff in emergency provision. This would be something that's consistently raised by people in our services and people with mental health issues more broadly. We know that as a member of the Anti-Stigma Global Alliance, but also from recent research in the UK, that health and social care staff are the most difficult to influence in terms of their attitudes and behaviours around mental health, and Northern Ireland is disadvantaged for never having had a general anti-stigma campaign in contrast to the rest of the UK. I suppose that would just bring me on to the point that a lot of the international human rights instruments are ratified by the UK, and although we obviously would respect the fact that health is a devolved responsibility of the Northern Ireland Executive, we would express significant concerns that there's a clear difference in terms of how the right to health for people with mental health issues is delivered on in Northern Ireland compared to the rest of the UK. And in particular, we would draw attention to the emergent policy of what is called parity of respect and investment in mental health and physical health. That's a policy of the Westminster government. There's a clear evidence base for doing that, and there's a clear process of work being undertaken. It's been included in the NHS mandate, for example, and clearly in Northern Ireland there's not parity of investment in mental health and physical health care, and that then has consequences in terms of emergency care as well. So I suppose those would be the main overarching issues. We also just wanted to reference the forthcoming Mental Capacity Northern Ireland bill as well. We did a consultation with people with lived experience and their advocates over the summer to inform the Department of Health's consultation on the provisions of the legislation. And obviously this is going to be the legislation which has huge human rights implications, because it will be the legislation in which people are deprived of their liberty, either through detention, restraint, forced treatment or compulsory residence. And we have serious concerns that Clause 65 of the proposed legislation includes an emergency provision. So if something is deemed to be an emergency, a whole raft of safeguards around serious interventions which have human rights relevance are set to one side. And I suppose that would go back to what I sort of said earlier, that we feel that a lot of mental health emergencies could be easily avoided if there was proper investment and provision. Thank you.
Okay, thank you. Harris, if I can start and ask a couple of questions. I wonder, first of all, drawing on the case examples that I know you have, I wonder if you take us through what you see as the key resource and non-resource issues for emergency department. And I'm thinking here of not just the emergency department itself, but the ancillary services that obviously determine who gets in and how you move out of the emergency department. So I'm talking about community care, out-of-hours service, doctor services, minor injury units, all of those services that impinge on the emergency department. So give us some of the case examples of the issues you're dealing with and what you see then as the key issues for people with mental health problems.
I did have one issue which is actually current. The person concerned is still an inpatient in one of the mental health wards, but this gives you an example of somebody who has severe and enduring mental health condition. He's got a diagnosis of schizoaffective disorder, and I only reference a psychiatric disorder to sort of say it's relevant in terms of he has paranoid delusions, particularly around paramilitaries, and also in terms of the affective component. When he becomes unwell, he will do things like give away his possessions and his money, so that is relevant in terms of the pathway. So I wanted to take you through that case study because it illustrates a number of, it'll do a number of touch points in terms of the issues that you've just raised here. So it's quite long, but hopefully it'll feel relevant to yourselves. As I say, this is a man, he lives in, he did live in a flat in one of our supported accommodation services. Although he has a serious and enduring mental health issue, he's very well supported, and for us, the whole focus around mental health is around recovery. So he's recovered his mental health, he was stabilised, he was living independently in the community with support from ourselves. He began to deteriorate in his condition. Another factor for him as well is he's from a village in Ireland, but he's lived in England for quite a long period of time, so he has an English accent, and also he doesn't come from Northern Ireland, so in terms of his delusions around paramilitaries, it's not particularly on one side or the other. He just becomes quite paranoid about the presence of paramilitaries. So he himself, in keeping with the recovery model, identified that he was becoming unwell, living in the community over the summer. He went to his community mental health team that he's in the care of and said, I'm really unwell, I think I need to go into hospital. He was then given an appointment for the next week, so he had to get himself through the weekend before he could actually engage with his mental health team. By the Sunday, he was so unwell, he just felt he had to go to A&E as a route into a hospital admission for mental health. And I think that's, when we look at A&E, it is both a provider of physical and mental health services, but it's also a gateway into services. It's a way of fast tracking. And this is somebody who is very unwell, is known to services, tried to access services in a considered, planned way, and that wasn't possible for him, and therefore he ends up in an A&E situation. When he presented at A&E, there was no inpatient bed available for him, so he was put into the care of the home treatment team. And they took him back to our residence for him. Our service manager had to go out and let him in because he'd put his keys through the letterbox, because as far as he was concerned, I'm very unwell, I will go to A&E, I will ask for help, and I'm not coming back here, so I just put my keys through the door. He then had to, that was the 10th of August, so that's the sort of starting point in terms of an A&E presentation. He spent 2 weeks trying to be admitted to a mental health hospital bed, went to A&E, engaged with this community mental health team, engaged with the home care team, just multiple attempts of somebody with a mental health condition trying to get appropriate support that isn't about going into a crisis, primarily physical care environment. Part of his deterioration of his condition was that he became increasingly paranoid, and he went up to the local loyalist bar and started calling out their customers who were associated with a paramilitary organisation. as a result of that, he was threatened, and we had it confirmed by the community that there was 2 people with hammers had been sent out to get him, to physically attack him. That was the 22nd of August. He'd also deteriorated in terms of how he was managing his flat and how he was behaving to female members of staff in the service. And so on the 23rd of August, he had a forced eviction from our house. So in terms of his right to live independently in the community, his right to home, his right to family, his right to privacy, because this was now being played out in the entire community about how his mental health had deteriorated. He then moved into a room in a shared house, and his mental health continued to deteriorate. Then one of the things that he did was he then went up into a Republican area and went to a pub and called out the customers who were associated with a Republican paramilitary organisation. So we then, in this situation, even in terms of his, not only his right to health but his right to life, he actually then had 2 quite antagonistic situations had been created with paramilitary organisations. Throughout that whole time, although it might be presented that he had access to a community mental health team and a home care treatment team, and he was in our service, we had very little support from the home treatment team, and the colleague who runs the service would sort of say in his area they call the home treatment team the no treatment team because they simply don't share information with us. There's no integration of care between the voluntary sector and the community and the statutory sector. There was very little support for him other to make sure he was taking his medication. His mental health deteriorated to the extent that it just felt unsafe for him to be in the house, unsafe for himself in the sense that he was now planning to go out around a whole series of other pubs and call out other people. He was threatening towards staff, he was threatening towards residents. We asked the home care team to turn up to take him into hospital. They turned up maybe about an hour and a half later, by which stage we contacted the out-of-hours GP. The out-of-hours GP wouldn't get involved because the home treatment team was involved. So again, we tried to get emergency care from the GP service and were refused that support. And eventually the home treatment team came out and got an ambulance. So we ended up having to use an ambulance resource to get him into A&E. And from there he was admitted, and he's still on the hospital ward. And he's had to be moved around within the mental health hospital situation because his mental health is so bad that he thinks Lucifer is on some of the wards. So I just sort of think in terms of now as we sit today in October, he is still an inpatient in a ward, but he is dealing with a massive deterioration in his mental health, and he's having to live now with the consequences of having lost his home, having been under threat, and it's going to take a long time for him to recover not only his mental health but also his entire life, really, in some ways. So I think for us that would illustrate how emergency mental health care isn't delivering, but also then when people touch off emergency physical care, that's not working either. And it's just a sort of story about how is it possible that when somebody is in mental health services and seeks support, you end up in a situation where ambulance services are involved, A&E services are involved, and the advice we had from the local community mental health team was, well, if that happens again, call the police. So in theory, if we had been that way minded, we would have got the police involved in that situation and he would have been taken out of our service in handcuffs.
Okay, I mean, that's really helpful because that's a very stark illustration of the impact of community-based mental health services and support has on emergency departments and kind of healthcare and perhaps not spending money in one place ends up more money being spent somewhere else. I wonder if you then move to the emergency department itself, what are the issues there in terms of how ED deals with people with mental health problems? What are the kind of key issues for you in terms of the hospital itself?
Yeah. In that, I suppose we had a lot of comment around the impact of stigmatising attitudes of staff towards people who turned up distressed because they had maybe had a physical health problem as a result of self-harm, and so they'd overdosed or they'd cut themselves. And then we also had an issue around what happens when people repeatedly turn up at A&E and how long it takes for that to trigger something externally in the community mental health system. So in terms of negative experience is this is just such a consistent piece of work. I haven't got one case study. It's every time I asked anybody about A&E, this is what consistently was being said by our staff members who would often accompany people to A&E, but also by people in our services. And some people in our services have kind of, you know, at quite an early stage of developing mental health issues and hopefully will recover and come back out of it. Other people have maybe been in mental health services for 20, 30 years, including institutional care. All of them would consistently say there is a major challenge in terms of people's training around mental health. So actually identifying that somebody has got a mental health issue, and that goes back to what I was saying around a lot of people with physical health problems actually have mental health problems as well, and the importance of triaging them. So you identify there's a mental health issue here as well. So actually this person, it's not appropriate that they are triaged to sit in the waiting room, or we need to find a way of keeping them quiet and supported while they're also having their physical health issue dealt with. There's also the people who come in with self-harm, and that is really about attitude. And I think this is why we would sort of very much see A&E as a physical emergency healthcare service, and I think that's how the staff see it as well. So when people come in who are distressed mentally, then they're treated as, why are you using up a resource? Well, you're not really sick. Why are you taking up our time? And they're treated in quite a kind of dismissive and punitive way. So people would have experiences where staff do not directly engage with the person who is the patient. They will talk to the staff, they will talk to everybody around them, but they won't actually just talk to the person. And our staff members have said they've had to direct A&E staff to speak to the patient and not themselves. They treat people as if their health condition is of a secondary importance. So there's clearly a status thing there. If you go in with a physical health issue, that's one thing. But if you go in with a mental health issue, you're treated differently, even if you're going in with an injury of some form. So there's a whole sort of sense of, you know, we'll get to you when we are ready, and people are left to wait for quite long periods of time. Sometimes that is articulated verbally to people, but there's a strong sense in terms of people how their body language, their eye contact, that's how people get to know that they're not a priority in A&E. There's a real dismissal of the psychological pain that is being expressed through self-harm. So there's a real attitude of, you know, why are you doing this to yourself? You know, not appreciating that is just such an expression of deep distress, and therefore they're looking at a symptom that needs to be engaged with psychologically. I think as well, one colleague was describing an incident where she and another staff member were in a cubicle with somebody who had self-harmed, and two doctors were outside of the cubicle. One doctor was very clearly alerting another medical colleague to the fact that there was staff members inside of the cubicle and that they needed to talk differently because there was somebody from our organisation on the other side of the curtain. And she very much took that as a point that we see certain things because we're there accompanying and supporting somebody, but if somebody is going in by themselves, there's none of that editing going on, so maybe we're only seeing a partial part of it. And ultimately then what we're sort of saying is people being denied healthcare because they're presenting as self-harming. So one colleague who is a nurse, described somebody being sutured without pain relief for quite a deep cut. So this kind of punishment of somebody who has self-harmed rather than addressing their physical distress. I think the experience is so difficult in A&E for people with mental health issues, particularly people who self-harm, that people will not go to A&E, or they won't go to certain A&Es. So we have one service where people who are in our service very explicitly say, well, I won't go to that A&E, I will wait through the night, and in the morning I will go to that other A&E. And what's useful to learn from that is that the A&E they will go to is co-located with a mental health service, which is open on the weekends and will do assessments. And there's a strong sense that there's a much more integrated care, and it's much more destigmatising. So nurses in A&E or doctors in A&Es see their colleagues working in a mental health service, and so it's much less stigmatised. I think the other thing that people are doing apparently is not cutting themselves too deep, and then letting the wound heal themselves. So they're just so distressed that they will cut themselves, but they won't go so deep that they know they're going to have to get stitches of some sort, which in some ways is a grotesque indicator of how bad the situation is in A&E. And then just briefly, we've also recently had an incident where a woman took 4 overdoses in 5 weeks and had to be kept in overnight for a liver flush. And one thing was that she was put on a general ward, so she wasn't actually, there was no engagement with her psychological care needs. But it also that it took four overdoses, 4 serious overdoses for the team, what would have been called liaison psychiatry, for them to actually say, we need to review this case. So we would have a sense that it's a very high threshold for A&E to actually identify there's something so serious going on with this person. We can keep watching them coming in and in and in, or we can take a review, but that's quite far down the line. And I know certainly in that situation, it was extremely distressing for the family members as well, because I think our service was having to negotiate it, but also the family members were having to keep going in with her every time she'd overdosed, and really we're just getting very, very little support from A&E staff.
Okay, thank you. One final question from me before I pass you to Marion. In your opening statement, you talked about an anti-stigma campaign and what's been run in Britain, and also I think you talked about a kind of a right to respect in an NHS mandate. I wonder if you'd say a bit more about both of those, but what impact you think they've had in practice in Britain, and therefore what it would bring to the table in Northern Ireland if those were adopted as campaigns in terms of emergency department.
Yes. As I mentioned, we're a member of the Global Anti-Stigma Campaign, and I must say it is something that is significant, is repeatedly recognised around the world, that health and social care professionals are a particular challenge in terms of anti-stigma, and so we would not only be able to draw on an evidence base to share with the public inquiry from the UK, but we'd also be able to draw on examples. Denmark is doing some work in this area, so is Australia and New Zealand. So there's a range of different areas. So I think what I would sort of say on that, it is a well-recognised challenge that people have. In terms of anti-stigma in the UK, we have Time to Change in England, and we have Time to Change in Wales, and we have a See Me refounded campaign in Scotland. So there's 3 very well-established campaigns, now probably well into a decade of work being done. And I think then it is very noticeable the fact that in Northern Ireland we do not have a regional anti-stigma campaign. The campaigns in the other areas are co-funded between Comic Relief, Big Lottery and the state, so there is a particular model there, and NIAMH has received developmental money to start looking at getting an anti-stigma campaign going in Northern Ireland. I think one of the challenges in Northern Ireland is that we don't have a mental health and wellbeing strategy, and we haven't since 2008. And again, we're the only part of the UK that literally does not have a policy framework out of which the anti-stigma work can fall in the way that it has in England, Scotland and Wales. In terms of progress, one of the things I would sort of say with Time to Change in England is that was a very well-resourced campaign, and it had a £3 million evaluation budget, so there was a lot of really rigorous research being done, and what they saw was significant change in communities, workplaces, also in Parliament as well, in terms of change in attitudes and positive public engagement, and publicly people saying that they had mental health issues, but health and social care staff were the only area that they just couldn't claim, even with a massive investment, that they had made a shift there. But I think part of that conversation has opened up this whole discussion about we need to invest in mental health services, and part of the reason that mental health is publicly stigmatised is the fact that it's very under-resourced. It's treated quite dismissively in terms of the public finances, and so there has been a commitment now for parity of investment, and that was so in simple terms, the coalition government, when it came in, its policy, no health without mental health, was underpinned by an economic analysis, and that then led to a kind of key list of actions, and then part of that was putting it into the NHS mandate, and once it's in the NHS mandate, it's mandatory that money will be found. Interestingly, though, when I talk to my colleagues in Mind, they've said that Monitor, which is one of the new public bodies, just decided not to implement that bit of the NHS mandate. So I think there's learning for that there in terms of how difficult it is to progress proper funding for mental health. But I think there's a lot of good experience there. The other thing as well is that they've got what's called the Mental Health Crisis Concordat. Now it's only in England, but that's a kind of a document that a whole range of public and voluntary services can sign up to. And it's been interesting as well because it's a document that obviously we can share with you, but part of signing up to it is that you say that you're going to do a certain initiative. And out of that, so we would have things like triaging, street triaging. So if somebody's unwell in a public space, that it says there's a street triage, for example, with the police and health services, and people are supported appropriately. So there's a lot of very innovative work coming out of the Crisis Concordat that you could look at and sort of think that there's learning there for ourselves.
Okay, thank you. Marion.
Just two questions. One of them is about the 10,000 voices work that is done in emergency care. Have you much information on that and how it impacted or how people's mental health problems fed into that?
I can't actually, no. I mean, I would need to go back and get some information about that and send it through to you. What information would be useful for you on that?
I was just wondering, that it attempted to get people's experience of emergency care.
Mm-hmm.
And I think there were 5,000 people responding. I'm just wondering, are you conscious of what degree people who were presenting at AME with mental
health
problems
issue were included?
or people who had physical problems but also had mental health problems, felt that the two things maybe impacted on how they were dealt with?
I'll certainly come back to you. I mean, that's something I can get that information.
Is it something that you had been conscious of? Or?
No, and I must say nobody in our services even raised it. And I did put that call out to all our services across the 5 health and social care trusts, and nobody has sort of said we've engaged with this. So
Probably need to be prompt. Anyhow, the other question I have is about your involvement in the planning and delivery of services, which either on a community basis or at emergency department level. And have you any examples of good practice in that which would have a read across to the future?
Certainly, Niamh, through, I would imagine more on our service side and at our director level and associate director, that people would have an involvement there and would have involvement. I suppose one of the things we've identified through Transforming Your Care is the local commissioning groups and trying to engage with them and inform them in terms of how services are developing. From a policy perspective, I would engage with the Health and Social Care Board and Bamford Monitoring Group, just looking, I think we are still trying to keep the flame of the Bamford Review alive, even though, it often feels quite dimmed. Mm-hmm. We would have engaged around Transforming Your Care substantially to try, because we identified that as a real opportunity to look at mental health, because we were, in terms of the consultation document, we were very disappointed by how little there was on mental health. We felt it was just a bit of a Bamford Review selection of a short list. And in our submissions, we did make the point that this is also about mental health in physical healthcare services as well as improving mental health services. And we felt that we had no traction really achieved through that process. And we did invest a great deal of time in consultations with the Transforming Your Care team. We engaged a lot with our service users to try and get, a lot of detail from them about what did they want in terms of this new vision for services. And, we've expressed our disappointment to the Transforming Your Care team that this just felt very irrelevant to mental health, both in terms of mental health services, but also in terms of our access to physical healthcare services. And so almost we're back on, looking at Bamford, looking to see is there opportunities there. We're also, I think that the other issue for us is really looking at the mental capacity legislation, because we just are deeply concerned that legislation either won't work or will play out in a very negative way for people in terms of their human rights if there's not proper services in place around it. So I think, certainly speaking as a policy professional, I think in Northern Ireland the state provides a particular process for community and voluntary sector engagement with policy process, but I do not see a huge degree of traction in terms of kind of meaningful change. I think largely a direction is set by the time the consultation document comes out. And so literally I think what we're looking at is where are the spaces we might be able to influence things like the commissioning groups or on specific initiatives. I mean, the other thing I think which was very important for us was the disability strategy, and again, it is hard to overstate our disappointment with the disability strategy. It's an extremely weak document and falls very short of the Convention on the Rights of People with Disabilities. We're so disappointed in that we're now part of a mental health civil society alliance who's going to produce a UK civil society report on mental health and the Disability Convention, and we will have a great deal to say about the disability strategy in Northern Ireland.
Is there any way, Iris, you can see your way into the sort of preparation of the policy, and input at that stage before it comes out? Because you're obviously feeling that by the time it comes out, the path to some degree has been predetermined. Yes,
I mean, that's a very good point. And one of the pieces of work we have been involved with is the new health and wellbeing strategy. And the department has taken the approach of doing pre-consultation. So, for example, we're leading on the pre-consultation around employment and mental health and wellbeing. So they've taken that approach, which is welcome. That said, we've been waiting since 2008 for a mental health and wellbeing strategy. So pre-consultation is one way of having a conversation with us, but we still don't have a consultation document. So, I mean, I don't mean to be negative, because our approach to policy is very much looking at where are there opportunities, but certainly, I mean, I've been in post now for 2.5 years, and I do not see a good quality of engagement or results for us. And I think when we're also then on the other side hearing these kind of dreadful situations for people in a very day-to-day lived experience way, it feels not good enough, really, in terms of a policy process. It's not adequate, I think the other thing for us as well is, I mean, there's an issue in terms of our engagement, but I think it's really important to look at how the state invests in supporting people with mental health issues to directly engage in the policy and commissioning process, and certainly that's been a very strong theme that's been articulated through the Mental Capacity Bill consultation, that people are saying we just can't keep doing this is too important, you need to invest in our networks so we can directly be part of the policy. And now I think people are at the point, because they've had such difficult experiences of consultation, that they're now saying we want to co-produce policy and services. We've gone past consulting and engaging in dialogue around it.
Thanks a lot.
Yeah, thank you.
Thank you. Thanks a lot, Iris. In your documents, in the documents of your organisation, there are quite a few references to human rights, which is great. And we know that the trusts have human rights officers. They have slightly different names, but I'll call them human rights officers for short. When you're engaging with the trusts, do you find them responsive to the human rights discourse and analysis that you use in your material?
I think one of the challenges when we're engaging with state actors is that they understand that there are human rights protections. They understand, as a consequence of the Northern Ireland Act, that there's enhanced protections because of the particular circumstances of Northern Ireland. But there is a lack of training and confidence and depth of engagement in terms of what that looks like in terms of a lived experience. So, for example, when you look at some of the work that the British Institute of Human Rights might have done over in England, where you're looking at a care setting and you're saying, okay, well, what does the right to health mean? What does the right to privacy mean in this live context? There's a lack of that kind of depth of engagement. I must say, though, when we responded to the adult safeguarding strategy, and we had put in, it's the only time a state actor has ever come back to me and said, you mentioned human rights in your submission. If we put it in, can you work with us to work out what that would mean? So there is that kind of commitment in the adult safeguarding strategy, and they are looking to how does that actually read down into practice. But I think it's quite distant from people understanding what it means, other than in a maybe statutory regulatory protectionist kind of way. I don't necessarily think that they think it's a positive way that they can talk to people who they provide services to. I don't think that's there for them.
So it's not that they're opposed to it, it's just that they have the trouble grasping what it means in practice. Is that a fair way of understanding it?
Yes, I do believe that. I also believe it's not an imperative within their organisation. So I don't have a sense when I talk to them about different levers to try and create change, and I mention human rights, there's a kind of, we know we're supposed to be doing that, so we will engage with you, but it'll not be a substantial engagement. I mean, the only time I think human rights has garnered a significant response has been because the UK is going to have its first review on the Convention on Disability, and the closer that gets, unfortunately it's been postponed, but the closer that gets, there is a kind of moment where I think they realise somewhere somebody is going to have to report up to this, and this we need to have something to say, really. So that has started to provide traction. But if I go back to the example, for example, the mental capacity legislation, we've consistently said this has to be human rights compliant. We're very concerned about human rights compliance of that legislation. And it's been very difficult to get traction in a meaningful way around that. Now what we're doing is sort of saying that our legislation looks very similar to what they have in England and Wales, and England and Wales are reviewing human rights compliance of their legislation, and through that route I think somehow the message is coming back to the Department of Health and Justice that they are going to have to look at human rights compliance too.
I'm very interested that you hear that when the UK is going to be appearing before a UN human rights treaty body, then that can be a trigger for the authorities in Northern Ireland to give more attention to human rights. I find that rather interesting. You referred to the Disabilities Committee. What about the other UN human rights treaty bodies? Do they attract this? Do they act as a trigger in the same way, or is it really the Disabilities Convention Committee?
I suppose because we're a mental health organisation, we would largely use the disability one. So, although we sometimes would refer to others, that would be the main emphasis for us. Even, for example, which is on a separate issue, but on welfare reform, when we were arguing for the establishment of the ad hoc committee on equality compliance, we used the Northern Ireland Act, we used the European Convention on Human Rights, and then we used the UN Disability Convention. Those were sort of the three that we tried to create a bit of energy around.
You referred to the local commissioning groups, and that was helpful, thank you. Is there, in your sort of work plan, in your universe, would you be thinking about trying to engage with the commissioning board itself, or is your route into the commissioning board through the local commissioning groups? I'm just trying to understand whether it's through the local commissioning groups whether you would engage with them, or would you, on some occasion, you or your colleagues, go to the commissioning board itself? We would do both.
We would engage with the Health and Social Care Board on a number of different issues, actually. Yeah, so we'd have several meetings. I would have meetings with them, but also colleagues in other parts of the organisation would as well, who are involved in direct service provision.
And for commissioning purposes, in the context of the commissioning issue, you would engage?
It would be around commissioning, but I mean, appropriately, because we are a service provider, there's clearly, we wouldn't be talking about commissioning in that sort of way to them. I think we would be quite cautious about that, but we would talk about policy intent. And I think particularly for us, because the Bamford Review has been such a major framework, and I think at this stage all parties would recognise that there wasn't strong central commission, and so there's been a massive variation in terms of what's in each of the health and social care trusts. So it tends to be more at that kind of level of looking at
I didn't catch what you said there. Excuse me, Iris. Did you say there's been a lot of variation in trust response?
Around yes, because when the Bamford Review, when it was being substantially resourced, there wasn't a sort of central leadership there around, or there was central leadership. I don't want to be disrespectful to my colleagues in the board, but it wasn't consistently enough applied. And so I think our sense would be that the health and social care trusts were at a level given quite a lot of leeway to pick what parts of the Bamford Review they resourced. And so you have a very uneven spread of the services across Northern Ireland, depending on what the interest was in the trust area.
And you refer to the trust boards. My last question or my last point is that when you look at the composition of these boards, by which I mean when you look at who sits on them, is your perception that those boards, broadly speaking, are reflective of the diverse composition of Northern Irish society?
I wouldn't be able to respond immediately to that. I would need to actually have a look at who's on each of the boards to come back.
And it was your perception that, rather than the data, I wasn't expecting you to have the data. I just wondered if you had a sort of impression.
I'd be cautious about giving you an impression.
Thank you. Thank you very much, Iris.
Thank you.
Thank you.
Okay, Iris, thank you. We've made the same invitation to everybody who's given evidence to us, which is that if you want to augment any written evidence you've provided to date, that would be very welcome. And in particular, I think we would find it very useful to hear a bit more about the mental health covenant, about some of the impacts of the anti-stigma campaigns in England, Scotland and Wales, and also anything that might be useful in terms of your engagement on the adult safeguarding side, where the idea of looking at human rights principles and concepts has happened in practice. So anything on any of those three things in particular, I think, would be very useful. Thanks for coming today. It's been very helpful to us. And really, it's just then finally, is there anything finally you would like to say to us to end on, or is there anything you think you've not covered that you'd like to say in conclusion?
I suppose one of the points we also frequently make in our submissions is the relationship between the very high levels of mental ill health in Northern Ireland and the conflict, and related to that, issues around deprivation. And obviously we would look to the Commission in a particular way, because you are part of the independent monitoring mechanism. We were concerned to hear that the UK Independent Monitoring Mechanism report wasn't going to make reference to the conflict in Northern Ireland and its relationship to disability, particularly for us in terms of mental health. And the explanation that was given to that was that the UN didn't give you enough of a page allowance to reference the decades of conflict. And that is just a concern that we would have, because I think all of what we discuss about mental health in Northern Ireland can't be separated from the experience of the conflict, because there's such a high demand for mental health support as a consequence of that. And then obviously there's an interrelationship there between people's mental and physical health and other disabilities as well as mental health. So that would be just a point we'd like to make.
Okay, thank you. And thank you for coming this afternoon. That's been really helpful. Thanks a lot.
Great. Thank you.
Okay.
Thank you for the invitation.
Yes.
Appreciate it.
Not at all. Thanks.